Hey everyone, we've got another heart today. This is number 820 in our collection. And we'll go ahead and start off with a quick teaser of what we'll actually be focusing on today in this heart and the key feature of this heart. And that, in fact, is the right atrium here. Here is the oval fossa, and there's an oval fossa defect. But then right here is the superior caval vein that drains into the right atrium. And here we find that superior to the oval fossa, there in fact is another interatrial communication, and this is in fact a superior sinus venosus interatrial communication. So here's the SVC, the superior caval vein, draining in to the right atrium, and here you can see the SVC and where it drains, and then here is an interatrial communication that sits superior to an oval fossa atrial septal defect. This, in fact, is a superior sinus venosus defect, and we can see some pulmonary veins draining into that defect. So now that we've kind of highlighted the key feature, we'll look at it again and revisit it in more detail. But let's get ourselves oriented the rest of the heart first. Anterior surface coming out towards the screen, posterior surface towards the turntable, head or superior here, legs are inferior here, left over here, right over here. We'll start off as we usually do, which is by trying to identify the right atrial appendage, at least externally. And here we find an atrial appendage that's triangular, broad-based or pyramidal in shape, all consistent with a morphologic right atrium, at least externally. And here we can see that the shape is a little changed and perturbed by previous suture lines, which is why I always stress that at least externally, the right atrial appendage looks to be right atrial or left atrial appendage, but the internal features are going to be what truly define the characteristics of the atrium, because externally the atrial appendages can be abnormal in their appearance because of surgical changes. So when we go ahead and open up this atrium, we do find that there's pectinate muscles that spill outside the confines of the appendage, all consistent with the morphologic right atrium. And we've already kind of gone through the major feature of this heart, but clearly there's more circles and holes in this atrium than we would expect. Here is the oval fossa, and there's a large oval fossa atrial septal defect. And then above it is an interatrial communication that's not truly in the atrial septum and sits by the superior caval vein, consistent with a superior sinus venosus defect. Now, I purposely call this an interatrial communication. As I stated previously, this is not truly a defect in the atrial septum. So while it creates a shunt between the left and the right atrium, it isn't actually truly a defect in the septum itself. In fact, we can see that there are right-sided pulmonary veins that drain anomalously through this defect. And in fact, it's the partial anomalous pulmonary venous return that highlights the main component of this defect. It is better to think of a superior or even inferior sinus venosus defect within the spectrum of partial anomalous pulmonary venous connection rather than atrial septal defects. Here's the superior caval vein that drains into the roof of the right-sided superior caval vein. And once again, here you can see the superior sinus venosus defect and then the oval fossa atrial septal defect. Elsewhere in the right atrium, we find the mouth of the coronary sinus, guarded by the Thebesian valve. Here we find the tendon of Totaro. And then here is the right-sided atrioventricular junction. The right-sided atrioventricular junction, the mouth of the coronary sinus, and the tendon of Totaro form the triangle of Koch. And it is at the apex of this triangle that we expect to find the atrioventricular node. So we'd expect the AV node in this heart to sit here. When we turn our attention to the right-sided atrioventricular junction, we do find that it's guarded by a valve with 3 leaflets, 1, 2, 3, and that this valve does in fact have direct connections to the ventricular septum, consistent with a morphologic tricuspid valve. When we take a look at this ventricle, it has coarse trabeculations. It also has a septomarginal trabeculation, aka a moderator band, all consistent with a morphologic right ventricle. Here you can see the septomarginal trabeculation as it gives rise to its cranial and caudal limbs. This is also known as the Y of the septal band. Now we come across our first arterial valve. This arterial valve is entirely supported by muscle. It has 3 leaflets, 1, 2, 3, with 3 sinuses, 1, 2, and 3. We don't see any coronary arteries arising from it. In fact, we do see pulmonary arteries that arise from it. Here's the left, and here's the right pulmonary artery arising from the pulmonary trunk. So here, in fact, is the pulmonary valve. And both the arterial valves, the pulmonary valve and the aortic valve, don't actually have a round or oval annulus, and we've covered this in previous videos, but I always want to highlight this. The true annulus, which is the boundary between the half-circle fibrous valvar leaflets and the myocardium here, is actually this crown-shaped appearance, because you can see that the fibrous valvar leaflets are kind of half-circle in shape, and then there's these triangles of myocardium that get interposed in between these valvar leaflets. So the true annulus of either arterial valve is crown-shaped or coronet in shape. The round or oval annulus that we create clinically is a helpful tool. We call it the basal ring, but it's not a true anatomic structure in the arterial valve. We'll go ahead and flip this heart to its posterior aspect. Here's the right atrial appendage. You can see some suture lines there as well. We'll go ahead and open up the other atrium now. And when we open up this atrium, we find that it's smooth-walled. All the pectinate muscles are confined within this appendage itself, consistent with a morphologic left atrium. Now, when we go ahead and take a look at this heart, we find that there is, once again, an oval fossa atrial septal defect here. And then higher up, we find the superior sinus venosus defect that allows for shunting between the 2 atria. All right, and we can actually go ahead and probe through so we can see it from both sides. So here's the right atrium again. We're going to put the probe through the superior sinus venosus defect. Now we'll go back to the posterior aspect, and here is the superior sinus venosus defect. Now, when we look at the left-sided atrioventricular junction, we find that it's guarded by a valve with 2 leaflets, 1, 2. There are no direct connections of this valve to the ventricular septum, consistent with a morphologic mitral valve. Here are the papillary muscles. And when we look at the ventricle that this drains into, we find that there's fine crisscross trabeculations consistent with the morphologic left ventricle. When we look at the left ventricular outflow tract, we find that there is another arterial valve here. A little difficult to open this up, my apologies. It does appear to have 3 leaflets, 1, 2, 3. There's a coronary artery arising here. This valve does not have entirely muscular support. There is fibrous continuity here with the anterior leaflet of the mitral valve consistent with the morphologic aortic valve. But once again, just like the pulmonary valve, the true annulus of the aortic valve is also crown-shaped or coronet in appearance, as the half-circle fibrous valvar leaflets have triangles of myocardium interposed between them. And then the ascending aorta back here. So once again, a heart with a superior sinus venosus defect, as well as an oval fossa atrial septal defect.